We move on to the last session for today, which is going to be chaired by Dr. Vijay Bada from Yashoda Hospital in Hyderabad. And the presenter is Dr. Biju Potagat, who is my former fellow from SGPGI Lucknow and is now the chief of GI surgery at JIPMER Pondicherry. Dr. Vijay, please.
Yeah, good evening, sir, all of you. After this very good discussion on the medical and endoscopic management and the indication for surgery, Biju sir will just enlighten us on the technical aspects of the various surgeries that are available at hand for treating a patient with chronic pancreatitis. So, Biju sir, over to you, sir.
Hello.
Yes, Biju.
Yeah,
Hello.
good evening and thank you. Overall, there is a philosophical bias in the surgical procedure. So when surgery is spoken, I feel that suddenly the discussion of pancreatitis, we treat it like a hepatitis, incurable disease, entire pancreas disease. And when endoscopic approaches are spoken, suddenly we talk about ductal anatomy, classifications, stone disease and all that. But at the end, probably in the last decade, chronic pancreatitis surgery became a very safe operation. And very few centers actually report mortality, and we have a very fewer complications overall. So the surgical results are improved tremendously, and this has to be accounted for. So overall, various classifications are there for surgical procedures, but generally they are drainage-only approaches, drainage dominant approaches, resection dominant approaches, and only resection approaches. So the earlier surgeries, Duval's, Pusto, and Partington's, they basically, with respect to the pancreas, they were only drainage only approaches. So when Frey's and Isbicki and other people introduced this sort of some partial resection, but ultimately they were all drainage dominant approach. So the dominant part of the surgery was still the drainage, and the resection was the subsidiary component of that surgery. So further, it went into resection dominant approaches where there is actually a en bloc or a piecemeal block resections are done rather than coring. And the idea was to preserve the duodenum and the bile duct and something short of a pupil, plus or minus with the drainage procedures. So resection only approaches are also there, like a total pancreatectomy, islet transplantation, pancreato, duodenectomy, distal pancreatectomy for specific indications. But this may come up if islet transplantation comes to a bigger arena. So overall speaking, what are the intraoperative targets if you opt for surgery? This is after opting for surgery. Most of the recent publications show that you have to remove at least a significant part of the head. It is better to preserve the bile duct and the duodenum. And you have to remove almost all stones and drainage of all pancreatic ducts. That means all the three major pancreatic ducts. This should be the targets in probably in the current era for any surgery in chronic pancreatitis. What is probably not recommended now is if you are operating, only drainage of main pancreatitis is probably not recommended, and only some part of coring of the head, leaving behind the disease remnant duct without managing the strictures and stones also not recommended. So why we are still, whether the disease in the tail, body or head, why we are concentrating on head? Because there is a philosophical pacemaker theory, and head region constitutes more volume. So whatever, whether it is Isbicki or head resection, whatever we are talking, the better results came with reducing the volume in the pancreas. That is where the better results of pain came, with reducing the volume in the pancreas. And head coring or head resection reduces the volume significantly. And head is the common location for stone, pseudosis, strictures, and most of the complications of chronic pancreatitis happens in the head. And head is a dominant location identified as the cause of pain, and the other two ducts are located in the head. So head coring is the most common procedure performed. But the problem with head coring is it's an anatomically less defined operation. You can do it minimum, you can do 5 gram, you can do 30 gram also, still call it head coring. And whenever the results are compared, all these surgically little bit less defined targets for performing surgery, all of them are compared in the same series, and ultimately the blame is put on the nature of the disease. Even if negative results are there, it is blamed on the nature of the chronic pancreatitis. So one of the least defined, anatomically defined operation is what we do is the Frey's procedure. So removal of all stones, majority of the head part to be removed, and drainage of all three ducts has to be done. And the idea of this surgery is you concentrate more on the head rather than body and tail. What is preserved in head coring is bile duct, duodenum, vascularity to the duodenum, pancreatobiliary ductal junction ampulla, posterior wall of the cavity, and bridge of the pancreatic tissue between SMA and posterior wall. So this is what is probably short of a people. This is what we have to, we can preserve. Remaining we can remove. So why Frey's procedure accepted very widely? Because it forms an extended drainage procedure. When you do Frey's, it is mostly guaranteed that all ducts are opened up, and salvaging surgeon for the LPJ, which is probably considered as an obsolete operation now, and avoiding pancreatoduodenectomy, and any even less trained pancreatic surgeon can do this Frey's procedure. But when you go to the original description of Frey, he himself defined it as a resection procedure, and probably the intention was to preserve the bile duct and duodenum and core out the majority of the head, and that's what probably the intention was, the same what we are discussing even today. So there are original and modified approaches. The modified approaches, the coring came more anteriorly when the laparoscopy surgery was introduced, but this coring line now is shifting more posteriorly in most of the large volume centers. That is probably the message we are trying to get, is the coring line is shifting more posteriorly. So the problem with the conventional Frey's is probably what is defined at that time was we stop at the area of the posterior-most duct. So you can see in the picture that a significant amount of pancreatic tissue, especially in a highly inflamed gland pancreatic head mass, it is left posterior to the duct, and there can be stones there, as you have seen in this picture. The problem with the chronic pancreatitis, especially patients with significant pain and other symptoms, is there is a dominant, there may be a regional dominance. Some patients' head may be a dominant site of disease, whereas in other patients, it may be the tail. So all patients are not the same, and the management has to be decided based upon the CT scan and what you see in the CT scan. So these two, both are chronic pancreatitis, but the approaches should be a little bit different in both the patients, because one is probably a head dominant disease, other is a ductal dominant pattern. And what we are discussing about the parenchymal dominant pattern, where stones are scattered everywhere, and this also probably the head resection will help. At the same time, when you partially resect the head, ducts should be open, duct will be visible in the head. You can extend it from the head to the tail. There is no need to identify the duct at the neck or the tail region before resecting the head. So there can be a situation where the head can be severely diseased with a severely diseased tail also. So the bottom line is this: your surgery has to be on the right side. It has to be somewhere near the ampulla. You have to stop, and the left side is to go right up to the splenic hilum, and the duct has to be completely open. Otherwise, the leftover stones and the undrained ducts, the results will be bad, and it will be blamed for the chronicity of the chronic pancreatitis, and actually it may not be due to the incomplete surgery. And the pseudocyst is nowadays we encounter is very often in chronic pancreatitis, and there is a risk of leaving pseudocyst in the head region if you don't core it or excise it very nicely. And so what we have to basically do is drainage of body and tail duct till the caudal pancreas. So if you talk tail of pancreas, the tip, the distalmost part of the pancreatic duct, the caudal pancreas might be left behind because of the splenic artery injury, vein injury, but that has to be opened. And if you have a stuck stones there, it is better to resect. And duodenum bile duct has to be resected, remaining you can remove. So probably basic operation which fits to the most is head coring variably extended in the head. You may add an Isbicki procedure plus or minus, and adding ductocystogenosis, what we call the duct and cyst anastomose together. So this is probably a term which we are also trying to push it like a ductocystogenosis, where in chronic pseudosis, you open this cyst and only cyst drainage is not enough. Still, you have to do a head coring along with the anastomosis to the cyst, even if it's located in the remote locations. So these are some of the pictures of cystoductogenostomy we have done. And intraoperative ultrasound is a very essential tool, especially in patients with a portal hypertension or stuck stones in the tail region. So you can use various energy devices, unipolar, bipolar, harmonic devices, whatever you use. Normally, in without portal hypertension, the blood loss is acceptable, and it's probably a surgeon's choice. And your left hand behind a completely coccygeal duodenum, left hand behind, will give a very good clue about the extent of your head coring, whether you are actually gone much beyond the all three ducts in the head region. Even in portal hypertension, sometimes if the head region has less collaterals, you can still go ahead with the head coring, but sometimes it may be really difficult. So we little bit modified the head coring concept in this way. We go ahead with a more extended coring. So what we essentially do, the principle was leaving behind the pancreatic tissue behind the ducts will be problematic. And we extended the coring right to the posterior capsule. So what we do is we just take out the entire pancreatic tissue and we leave only the posterior capsule. So this posterior capsule is in a normal pancreas, and chronic pancreatitis looks quite different. In chronic pancreatitis, you will have a thick posterior wall, posterior capsule, and it will prevent the leak. So we go right to the posterior capsule, completely removing that part. And finally, the picture will be like this. This is what we call a more extended coring. And finally, after the coring, it will be just a simple thick layer of the posterior capsule without much pancreatic tissue. So this is our modification, what we do nowadays. And we also go right to the medial duodenal wall. So you identify the common channel. Sometimes you cut off the sphincter. Sometimes you enter to the sphincter to the bile duct to check that it is fine with the feeding tube. And basically, what you are ensuring is there is no stricture there up to the ampulla. Sometimes you cut the sphincter by for ensuring it. And the Wirsung and Santorini ducts are exposed nicely. So the difference is this is a little bit more of an anatomically defined operation. Leftover tissue is minimal, and you can also avoid a pancreatoduodenectomy.
3 more minutes, Biju. 3 more minutes.
Yes, sir. So the suturing, what we do not suture to the nowadays we do not suture to the pancreatic remnant. We suture to the duodenum on the entire C loop. And the suturing to the pancreas comes only in the body and tail region. Remaining will directly suture the jejunum to the duodenal serosa. And this is up to the July 20, the 10-year experience when we modified our approaches. When we compared with the 14 cases of bile duct intersection, that time our results were good. Nowadays, we do not perform a routine phrase at all, and we always perform an extended coring or extended resections. And we have done more than 40 of them now, and our results are, we don't have much complications. And except in one case where there was a small posterior capsule opening which was sutured, remaining patients had a similar outcome compared to phrase when we were doing phrase. And one of the probably anecdotal incident what we have noticed frequently, the number of readmissions has significantly came down, although it needs a long-term follow-up. And thank you very much, and that's what I wanted to say. Thank you very much.
Yeah. So before Dr. Vijay takes over, Biju, for the sake of students in the audience, can you please again clarify what is phrase, what is conservative phrase, what is extended phrase, and what is modified phrase, and what is your modification? Because students are always asked this question in the exam.
Okay. So phrase is what we are preserving is in a phrase is the duodenum and probably the arcade of the vessels around the duodenum with some pancreatic tissue next to the duodenum along with the bile duct, and the coring is done after up to just at the posterior level of the pancreatic duct. And on the left side, it is gone up to the neck of the pancreas. This is what is supposed to be the coring. So modified coring, modification in lesser way and greater way is also described. Lesser way is coring less than this, anything less than this, because when we see post phrase, we see some patient with post phrase done elsewhere. We also see significant amount of parenchyma left here. So this is less coring. More coring is you are going behind, much more excising all the ducts up to the posterior capsule. You are excising more to the duodenal margin and right up to the SMP. So probably there are three types of coring. I'm sure people may differ.
Yeah. Dr. Vijay, please take over. There is a comment by Dr. Puneet.
Yeah, thank you very much, sir, for your very elusive presentation and some of the modifications that you are bringing up to. First, we'll take Puneet sir's question. So, sir is asking that is cyst drainage required? Because you showed in one of the picture that when you drain the duct, you also incorporate the duodenocystogenostomy. So, his question is the cyst drainage really required when we are draining the main duct? Because obviously the control of the, we are doing the source control while draining the duct.
Yeah, the answer is we always do for various reasons. One, it's not mandatory that the ducts are always communicated with this. It can be a side branch, and we also found cysts are not in continuity very often on MRCP, and they can also be located in some remote locations which are not resolved or not accessible by endoscopy. Since we are operating and it doesn't add to the morbidity too much, we always add the drainage procedure along with that. That's the philosophy. But again, we have done almost around 14 cases like that, and we have to see our results.
Yeah.
Actually, they're quite
the same loop, I'm telling.
In all
we have done drainage separately before. I'm just telling about this procedure.
Yeah, all of the pseudocysts are not necessarily connected to the main duct. In most of the cases, we do see that. So, you want to add something, Puneet?
Hi, can I? Yeah. So, two things. One is he said if they may not be connected. If they are not connected, these are the classical ones which will resolve by themselves. Only the ones which are continuously being fed will be, will not reduce with time. So, the ones which are not connected. So, he also used the term not connected by MRCP. Now, that is, you may or may not see, we've been burnt our fingers a lot of times about MRCP as being the gold standard. I think we need a direct kind of either an ERCP or a direct ductogram to show where the leak is, if there is a leak. Sometimes the leak is too small to see, which I completely agree. But if it is actually not there, we, theoretically, suppose we know that it's not there, it probably doesn't need drainage. Pseudocyst is not a disease; it's a complication. It's a leakage of the pancreatic duct fluid. So if we are draining the duct, we are actually, and there are papers showing that if you drain the duct in a cyst, in a disease, in a chronic pancreatitis associated cyst, you don't actually need the cyst drainage. The surgery is complete. There are a couple of papers showing this very elegantly. And if it is in continuity, then it's, even if it's a side duct, so long as you're draining the duct, you've actually decompressed. So there will not be enough pressure generated to reform the cyst or to maintain the cyst.
Yeah. Yes, sir. Biju sir, I have one question. You already said that head coring should be mandatory in all surgeries for chronic pancreatitis. But there are few studies which have shown, and now we know that we are cross-section imaging, we can measure actually the volume of the head of the pancreas. if there is absolutely no evidence of a fibrotic head of the pancreas, no mass in the pancreas, but a grossly dilated duct, what is that extended lateral pancreaticojejunostomy, sir? Because there is a few studies as late as 22 where they have compared phrase with versus the extended lateral pancreaticojejunostomy, showing similar results in terms of pain control.
So I was talking about patients who already you are decided for surgery, then head removal, probably retaining the bile duct and duodenum as a philosophical principle.
Okay.
Yeah, the evidence has to come, but it is still, I'm telling, it is based upon a philosophy.
Yeah.
The philosophy is what I have explained.
You have any experience of the extended PJ? What are the limits of the extended PJ, sir?
On the left side?
Yeah.
Yeah. So on the left side, what we do is we go up to the splenic hilum and the tip of, sometimes the tip of the pancreas, you cut anteriorly. You may have to cut laterally and open it on the left side. Exactly at the tail, you may have to open it laterally and anastomose it. That will probably ensure that. So the tail will just dip to the posteriorly and upwards. You have to open and make a lateral. Your lateral most stitch has to come actually in the posterior part of the duct rather than the anterior part in the tail. And here on the right extreme side, we normally go up to the common channel and sphincter.
Do we ligate
kind of an amputation of the tail?
Yeah.
Yeah, amputation. And is it necessary to transect the GDA to in this extended pancreaticojejunostomy?
No, it's not. You need not go suprapancreatically and ligate it, but sometimes you may have to. Mostly, you will end. Sometimes you end up in ligating the anterior branch.
Okay. Okay.
There are few questions from the students. Vijay, can I take
Yes,
them?
sir. Please take.
So, since we have just 5 more minutes, and I'd like to give Dr. Vijay 2 minutes to make some concluding remarks. Biju, quick one-line answers for exam. If we are not able to remove uncinate process stones during phrase procedure, what to do? First is, how do you find whether you have been able to remove? And if you feel, then what to do?
So the idea is intra-op identification of stones is really difficult. So it is better that if you see that pre-op imaging, it is affected, it is better to remove the gland rather than poking and removing the stones, because there is a risk of always leaving behind the stone. So in the head region, even the uncinate duct, you have multiple stones, better to remove majority of the part till a small area is left for anastomosis. That will ensure, basically the purpose main why the extended coring is giving probably better results. It actually ensures that all ducts are definitely drained. That is one of the sure guarantee it gives. But if you go with the mindset that I will do only the duct drainage, probably the duct drainage will also may become suboptimal. That's why when we normally do not identify the ducts at the neck or body, we during the process of head excision, we identify duct and extend to the body and tail. So that is the result.
Yeah. Next is that can we drain the bile duct along with the MPD drainage procedure in the same rule limb? Obviously, if it is indicated.
Yeah, it can be done same loop, but what we do is we always put one loop. We do not put a straight anastomosis. So you do a PJ. Then the straight anastomosis ascending to the bile duct, that we don't do. We always put one loop down and then the next loop only we do the anastomosis. In case it leaks, sometimes, again I'm telling I don't have evidence for this particular thing, but we had maybe the bile flow through the PJ might be less. So put one loop down and then next loop you do. First loop PJ, next loop free, third loop edge.
Treatment of choice for chronic pancreatitis with pancreatic ascites, surgery or endotherapy?
I think I will not recommend surgery in the first sitting.
If the bile duct gets opened during phrase procedure, shall it be left open to drain into the cavity?
So it depends upon how it got opened. For example, you used a unipolar cautery and you try to score it and did the thermal damage. So I prefer to do an anastomosis. And the second thing is, if the duct is too small, undilated and scarred, putting a stitch and closing it might be a problem. So either do an edge or just leave it like that.
And a step before that, how do you ensure that an undilated bile duct doesn't get injured during head coring?
How to ensure? Okay. So practically speaking, on table, by experience regarding the you should have a clear understanding of where exactly the duct is located. In this procedure, what I described, we sometimes put the instruments, biliary guides and all that through the ampulla and reverse direct and demonstrate this duct sometimes in difficult cases. And you can always, if you have a problem, you can always do a cholecystectomy or do a cholangiogram from above and see and put a feeding tube down and see. But whatever the issue is, try not to injure the bile duct. And even if you injure it, do an HJ if it is because of the thermal injury. That's what my message.
Dr. Vijay, your concluding remarks, please.
Yeah, thank you, sir. It was a very good talk and a follow-up discussion on the most important aspect. I think one thing is very clear with the evidence and also the experience that head coring is a most important aspect of the surgery because only LPJ very rarely will be useful in the current set of the chronic pancreatitis patients that we are having. So we have to understand very clearly the marks of the boundaries of a good head coring. So head coring should be done completely. And as you said, that any intraoperative complications should be able to be held, dealt with very aptly. Thank you, Bijay, for a wonderful talk and very good discussion after that one. Thanks, Kapoor sir, for giving this opportunity.
I think Puneet has a last minute. Puneet, would you like to? Dr. Puneet?
Yes, I just wanted to, no, sorry. No, I just was wondering whether we should, a lot of times we've had patients on follow-up who have, gallstones or gallstone-related problems or a biliary, so should we routinely add a cholecystectomy?
No, sir, I won't do because there's no justification and on ethical grounds also, I don't think it is recommended.
Right, because some soft this thing that it might have been the pain we are attributing to chronic pancreatitis without actually any morphology, just because the two are coexisting, we are presuming it's because of that. Some small proportion may be, just like we say when you're opening right iliac fossa, should you add a appendicectomy with there? We don't say that it is irrational. No, I'm just wondering. Because I remember the ones where a lot of times we've had problems with gallstones or with biliary drainage later on. So there's always like you said, we should do a cholecystectomy for doing the cholangiogram, which I completely agree. I think that's a very good idea. So just a thought, it's always crossed my mind when these patients come back with stones or some stasis.
Okay, thank you very much, Biju. Thank you, Dr. Vijay, and thanks to all the faculty and panelists who joined, and thanks to all the delegates who joined. So again, if the students want to join Jaipur Surgical Tutorial, please send a WhatsApp message to Dr. Anand. I have been projecting his number in between. Please send a WhatsApp message to him, and we meet again tomorrow at 7 o'clock. Thank you very much. Good night. Good night, everyone.
Okay, good night.
Thank you, Himanshi. And once again, the technical support, as I mentioned in the beginning, is provided by Dr. Avinash, who's again one of my former fellow from SGPGI, now a practicing GI surgeon in Ahmedabad, and his team led by Himanshi Patel. Thank you. Thank you very much.
Thank you.
Thank you.